well.
Thank you. Hopefully you can all see my slides now, okay? So thanks for that introduction.
Yes, great,
Sally.
Mike.
Thanks for the introduction, Sally. So I'm Mike Goodwin, as Sally said, I'm Divisional Director at UHDB, University Hospital of Derby and Burton, but I'm also the Senior Responsible Officer for the Community Diagnostic Centre, and I'm here to give you a brief overview of all of the work that's gone in to developing the Community Diagnostic Centre programme for our locations. But I will only give you a brief overview, and there's a huge amount of work and a whole team that have inputted into this, and it's really unfortunate that I'm the only person here from the team today, but we're missing a couple of key people who it would have been really nice to have join us. And just a little bit, if I can, to start off with about diagnostics. So diagnostics is absolutely critical in healthcare and in the health of the nation more generally. In the NHS England, we do 1.5 billion diagnostic tests a year. So just, that's not a misprint, it is billion, not million. And we impact on more than 90% of patient care. And I'm sure many of you will know that from your own care, whether that's having an X-ray or a CT scan, or whether it's having your blood taken at your local GP, and lots of other different types of diagnostic tests. And diagnostics isn't just about diagnosis, as in the diagnosis of a disease. It's also about things like prevention through surveillance and keeping people well at home. We know that more of our populations are living with long-term conditions, so the monitoring and the checking on the well-being of people that are living with long-term conditions, they're absolutely a critical part of overall patient experience and the speed of all of our pathways. If you're referred in and need a trauma and orthopedic operation, for example, the time it takes to get through your diagnostic pathway is absolutely critical in how quickly we can get you the right treatment and get you back on your feet. Efficiency is also a really key point of diagnostics. If we can get the right test done on the right patient at the right time, it means fewer interventions. People don't present sicker, they present earlier on with their condition, and we manage to avoid admissions and reduce length of stay. And also from a sort of using diagnostics to understand the outcome of some of the interventions that we do in the health service, and ensuring that what we do delivers good, effective care for all of our local population. But we know that capacity in diagnostics just hasn't kept up with demand. We've seen over the last 5 years a 25% increase in diagnostic referrals across all the diagnostic test types. And a guy called Professor Sir Mike Richards did a review of diagnostics in the country back in October 2020, so in the height of the pandemic, and absolutely recognised that as a country in NHS England, we haven't had the diagnostic equipment growth that other countries have seen, and that diagnostic equipment hadn't kept pace with the growth in referrals. So what that looks like is, if you compare the NHS England to other economically developed countries or other countries in the EU, we've got fewer than half the average number of CT scanners that the rest of the European Union had during 2021. So it just shows that the sort of lack of investment over a number of years created a gap between the demand and our capacity to meet that demand. So the CDC programme was launched from the Mike Richards Diagnostic Review back in October 2020, with a significant national investment into creating community diagnostic centres as freestanding multi-diagnostic centres away from acute hospitals. And part of that is as a response to the pandemic. We were struggling to bring people in and keep people safe in the hospital at that particular point in time, and there was a movement towards the development of more freestanding centres away from the acute hospital sites for us to be able to process patients really effectively. But it's also really key in the purpose of the CDCs to try and improve overall population health outcomes and reduce health inequalities. So being able to put the community diagnostic centres out in areas of high health inequality, and to be able to target those areas to specifically reduce health inequalities was a great driving force behind our program. And obviously, key fundamentals, just increasing diagnostic capacity, and I'll come on to show you a few slides, not just from a sort of equipment point of view, but also the facilities, the workforce, and everything else that goes with it, with the aim of doing that in as productive and efficient a way as we possibly can. And not just using it to provide more diagnostics, but using diagnostics as a catalyst to be able to give improved clinical pathways across Joined Up Care Derbyshire, in this case, with greater personalised care available, more one-stop shop type of appointments, with more joined up care across primary, community and secondary care. And that fits very nicely with the Joined Up Care Derbyshire strategic aims for integrated care. It mirrors them almost identically. I won't go through them, but it does link very closely with our strategic aims across Joined Up Care Derbyshire. So in terms of the community's diagnostic centre scope, there are three main areas that we're focused on. So imaging with CT, MRI, ultrasound and plain film X-ray, pathology with phlebotomy and point of care testing, and cardiorespiratory or physiological measurement with things like, echocardiography, ECG, in that example, Holters, respiratory tests, and that type of thing. We made the choice, part of the national programme, endoscopy was included, but in Derbyshire we made the choice to exclude endoscopy. And the reason for that is, from a sort of facilities point of view, we had sufficient capacity in order to be able to meet the demand, and managing endoscopy suites in isolation is single sort of smaller units is quite difficult and doesn't give a great deal of scope for utilisation, particularly in some of our more remote locations that were chosen. As I said at the start, it's a huge programme, so we've done something like 10 business cases in total. And some of these business cases were very, very short notice. So the teams have worked incredibly hard to develop the programme and to be as successful as we have. We've secured £30 million worth of capital investment. We've spent some of that on equipment and some of our estates refresh, but also we're in the middle of developing the rest of the sites, which I'll come on to talk about in a second. We looked at a range of different options, including doing diagnostics in shopping malls and in various different types of estate. In the end, we opted to use a combination of existing NHS estate that's owned by UHDB and Derbyshire Community Health Services. And the main reason for that is, first of all, the sort of the ease of access for our patients and the locations of those services. But more, I think, just as importantly, I think, is the ability for us to be able to transform the existing services that are there, as well as the extensive investment in the actual fabric of the building, and to make sure that those buildings are, fit for purpose and really thriving as we sort of head into the next sort of phase of the life of those buildings. It is really extensive equipment investment as well, so I'll talk to you about that in a second. As well as the investment in capital, we've also had £25 million secured for financial year 24-25, and that's to help pay for all of the activity, including stuff like being able to recruit and train our workforce. We know nationally there are really hard to recruit professions like radiographers, sonographers, etc. That there isn't the national volume of those colleagues available for us to just simply recruit. So we're having to do lots of things, including recruiting local people and taking them through apprenticeships and working with universities, etc., to bring more colleagues into the organisations in the future. We're very keen that our model supports a one-stop model for diagnostics. So we're trying to use technology to enable patients to be able to choose when they have their blood test, where they have their blood test, And also, if they've got a blood test and an X-ray due, to try and synchronize those so that they can do them all at the same time, rather than having to go to multiple different locations geographically spread across Derbyshire, to be able to get it all done in one appointment in one location. As I mentioned, they are geographically spread, and we were conscious of things like demographics of the area when we chose to where to put our locations, as well as some of the health inequalities that I've already touched on. Key for us is improving local access, though, and reducing the waiting times. So those were the sort of key fundamental aims for our CDC programme. Those are the locations on screen. So we've got 5, although the sharp-eyed amongst you will notice that Tamworth isn't in Derbyshire, it's actually in Staffordshire, but it is part of the Joined Up Care Derbyshire programme, so I've included it here because it does impact on patients that come through University Hospitals of Derby and Burton. The other 4 locations at Florence Nightingale Community Hospital, Ilkeston, down on that M1 corridor, and serving populations that spread across both Derbyshire and Nottinghamshire. The Whitworth Community Hospital up in Matlock, and Walton Community Hospital in Chesterfield. In terms of what we're doing in each of the locations, so there's a little list here that shows some of the sort of main tests. We are putting an MRI scanner into Florence Nightingale. We already have put an MRI scanner into Florence Nightingale. We're just in the build process for 3 CT scanners at Florence Nightingale, and those are being manufactured right now, with a huge complex build programme. There's already X-ray, but we're adding to the facilities there, ultrasound, echo, phlebotomy and point of care and respiratory testing, all at that Florence Nightingale site. So that's a big site for Joined Up Care Derbyshire. For Sir Robert Peel, we're going with a mobile MRI and CT. So there's a little picture of the mobile scanner there. So that's a scanner that can move across our locations to be able to offer MRI and CT in a range of different places at different times, responding to the need of the local population. It is a huge truck. It's not a small little van. It's a huge back of a lorry job, but that gives us some added advantage to be able to offer more tests in more locations rather than being fixed to fixed assets in buildings. And as well as SRP offering the other tests as explained for Florence Nightingale. Ilkeston is interesting. We're putting a CT scanner over there, and we're putting an open MRI scanner. So that will be the first open MRI scanner in Derbyshire. And currently, patients who are either have got a really big body habitus or are claustrophobic and can't tolerate an MRI. So an MRI is the donut type scanner. They currently have to go to places like Leeds or even further away to have their scan. So us being able to offer open MRI scans in Ilkeston is a real advantage. Whitworth is a spoke site, so that's a smaller site and doesn't have the full range of services. That wasn't the original intention for the Whitworth site. We were hoping to be able to put mobile scanners onto that site, but unfortunately, because of logistical problems and health and safety issues getting access and egress from the main road, we just weren't able to do that on the site. So, but we are already open and live with X-ray, ultrasound, and phlebotomy and point of care at the Whitworth site. Walton, again, is a mobile site, but also offers all of the range of tests that I've previously described. Just at the top, it shows when they're due to open. So these are really complex builds and complex programs. So some of them have slipped back just a little bit, but we're keeping a good grip on the program and the project managers driving the estates teams and the various manufacturers to ensure that we keep on top of the timescales. This is just another couple of examples of some of the things that we've already done. So some X-ray equipment, the phlebotomy chairs, the MRI scanner at Florence Nightingale, and our ultrasound equipment that have all gone in. All of those rooms have been refreshed, repainted, and some of them were essentially derelict beforehand. So, it does really help us to keep those sites vibrant and developing. As I say, we're still in the sort of growth period of CDC, but we are already delivering 4,900 tests a week, and we're pretty much bang on our trajectory and our activity plan. We're at 98% currently, and that's mainly down to Christmas weeks where we were forced to downturn some activity that we weren't able to sustain, that we hadn't planned for. But all in all, the program is going really well, and delivering 4,900 tests each week, in addition to all of the tests that we already do, has some really significant patient benefits, which I'll talk about in a second. And in total, that's 279,744 tests, to be exact, that we've delivered so far in the program, which is huge volume. But by the end of April 24, so a few weeks time, or by April 24, in a few weeks time, we'll have delivered 325,000 tests. In terms of the patient impact, you can't see an enormous amount of detail on here, but what this basically shows us is this is our reported diagnostic performance as a system. And historically, we've always had a very short waiting list for diagnostic patients in Derbyshire, with normally less than 1% of patients waiting more than 6 weeks. During the pandemic, that jumped up, and we were up at 60% at one point when we were just not able to bring patients into our sites. And over time, we've built our capacity, built our activity, and whilst the increase in referrals has continued to go up year on year, we've started to bring that number back down, tackling the longest waiting and most clinically urgent patients first. And we're actually about 7 percentage points now better than the national average. So heading in the right direction. Still far more work to do, but we are doing that work. But an improving picture for patients waiting for diagnostic tests that are critical to their care. We've also done some work with NHS Elect on an experience-based design project at some of our CDC locations. And you can't really see the detail here, but essentially what this tells us is that we've gone out there and had lots of conversations with patients that are using our community diagnostic centres already. And both patients and staff have been overwhelmingly positive about the services that are being offered. And we've had really great feedback about the ease of access, being able to park directly outside, nip in, have your blood test, get back in the car and not pay for parking because it's so quick. The speed of appointments, the expertise and the friendliness of our colleagues has really shone through in all of that feedback. And it's really good to see as well, and hear the feedback from our colleagues, which has also been very positive about the work that they're doing out in our community diagnostic centres. We also look at things like, Google reviews, and over the last few months, the positivity about Florence Nightingale and Sir Robert Peel and Ilkeston about all of our diagnostic tests has really shone through in Google reviews. So we're getting really positive, consistent feedback from various different sources. As I say, this is still work in progress. So the last of the programs to be finished will be Walton, and that'll be in late 2024. But we're as a working group meeting monthly, making really great progress with the recruitment, the procurement, and the estates work, all of which is ongoing, and it will be a real challenge for all of our teams as we start to ramp up activity. We're really keen that this isn't just about the acute hospitals delivering more diagnostic tests. So we're really keen to engage with primary care clinical teams and of course our patients in the development of our clinical pathways, thinking about things like opening out access to GPs so that more GPs can get direct access for tests, being able to refer into the organisation with a pathway that takes the patient straight to the test so that the patient has the test before, where it's appropriate, before some of their clinical appointments so that they go to the clinical appointment with all of the information that the consultant, for example, will need to make a decision. In some appropriate areas, we're even thinking about open access for patients. So that there are some specific tests, for example, a chest X-ray, that we are looking to open up access to patients to be able to self-refer. And then thinking about coupled appointments so that patients can make sure that they come, have their either clinical appointment or another diagnostic appointment at the same time, so that we minimize the number of times that patients are having to come to duplicate appointments in different parts of our system. That's all I wanted to cover, Sally, in a nutshell, but I'd be really happy to have any questions that anybody might have and to have a bit more of a conversation about it, if that's okay.
Brilliant. Thanks, Mike. Thanks for a great overview of what's gone on. It sounds like a lot has happened already and still, exciting things to come as well. And I think it's great that you mentioned the sort of experience-based design bit, looking at the Google reviews and sort of how you're involving patients and the public going forward. I know you mentioned on the slide, if people do want to get involved, is there a contact number or email address or something that we could put in the chat for that?
Yeah, I'll just drop my email address into the chat now.
Brilliant. And I know we've got quite a lot of questions in the chat, which is brilliant. So I'll hand over to Mark. I don't think we've got any hands up at the moment, so we'll go straight to the chat, and I'll pass over to Mark to sort of have a look at those.
Hi there. Okay, the first one, Tracy Elder has a couple, so we'll start with hers. She's asked, are these buildings accessible to people who live in areas of multiple deprivation, for example, transport links, etc.?
Yeah, absolutely. So when we started working on the plan, we used the multiple deprivation information from the local authority to be able to map where the areas of deprivation and transport links against our referral patterns and demand. Oh, sorry, there's a bit of feedback.
Sorry, I think somebody's just come off mute, so I'm just trying to work out who it is.
Thinking about
Shall I try again?
Yeah, keep going, Mike.
So yeah, we mapped the areas of multiple deprivation versus our referrals and overlaid public transport links. And one of the advantages of using the community hospital site is that sort of existing infrastructure of transport links. Now, it's not perfect, I grant you, and there are certainly still big gaps. I noticed somebody's identified High Peak as a particular area. We did look at various options in the High Peak, but they just weren't viable for a range of reasons, mostly to do with the estate and the availability of space that we were able to secure. But yeah, we did consider all of that deprivation and transport links.
Thanks, Mike.
Okay, we have another question from Tracy, and it's sort of related to that. She says there are no transport links from High Peak to either Matlock or Chesterfield. Is this because cover for diagnostics is better in High Peak?
Well, no, I don't think it is particularly. So there were as I say, there were the conversations about whether we could use sites like Buxton, and I know there were conversations, as I mentioned, about Denton and Glossop were considered by other systems. Yeah, I think we have to acknowledge that we in this work, what we were guided towards were 3 community diagnostic centres for 1 million population, and we've ended up with 5, and we've tried to geographically spread them as best we could based on areas of deprivation and some of the areas of higher demand. That was the criteria that we used to try and meet the demand. But I accept that we haven't been able to put a diagnostic centre everywhere, and I think that's most obvious in High Peak.
Okay, next question is from Adrian Brzezinski, got his name right this month. Does Denton affect Glossop residents? He also put in another comment later, which I think is to do with this. He says Whitworth is the closest, but Denton is across the border. So does Denton affect Glossop residents?
Yeah, I'm not involved in the Denton development personally, but that's maybe something we could take away and look
sorry,
at.
the point was that Glossop and High Peak residents could get to Denton easier than the rest.
Yeah, I get that. I meant more from a mapping point of view. What they've done, I don't know. But that was certainly a conversation about the join between the various different systems that occupy that space, and how do we ensure that there is some additional capacity for residents in that locality, whether or not it meant crossing a county border.
Okay, the next question.
I think sorry, Mark, I'll just come to Peter. I think Peter's got his hand up, so I'll come to Peter now, and then we'll go back to the chat.
Yes, thanks for the presentation, Mike. It's a very encouraging development, but £30 million capital investment, it does sound a lot, but I guess a lot of this equipment and gear is hugely expensive. So I didn't hear you use the word game changer for Derbyshire, so perhaps I'll ask you to comment on that. But linked to that is that the 25 million to deliver more training and staff. Now, I've heard before that, the throughput of qualified staff to work the equipment has been somewhat restricted in the throughput. Do you think that there is sufficient coordination and training opportunities and recruitment to bring people through to actually make sure the new kit is properly operated to full its capacity?
Great questions. Thank you, Peter. So I'll take the second one first, if I can. I think the national challenge in terms of workforce is significant. There's no doubt about that. These are hard to recruit specialties, but professions. But because we started the CDC program with a really pragmatic approach, and we were quite quick off the mark in terms of our activity, we've been able to get ahead of a lot of other systems and to start to recruit, develop and retain our colleagues in greater number than in other localities. So I think we have done really well. Now, that's not to say it won't be a challenge, because I think it will continue to be. We've been really innovative with what we've done. So, for example, I mentioned the apprentice schemes. So we're trying to develop colleagues through apprenticeship programs to into professional roles, and trying to ensure that there are career pathways for people that are supported within the organisations to save them going elsewhere. We've also done things like, international recruitment from 5 or 6 recently from India, and we've got a mentorship program and support program when they come over to ensure that they're well looked after and really successful in our system. So I think we've done a lot to be as innovative as possible to try and get ahead of the curve and to close that gap. And I think, to answer your first question, I think the additional capacity is game changing. I think it does allow an enormous amount of clinical pathway redesign, and there are some questions about UTC and community and various different the ability for various different parts of our system to be able to access diagnostic capacity. We definitely wouldn't have been able to do that had we not done the 10 business cases and secured all of that additional money. You're absolutely right, 30 million isn't a huge amount of money when it comes to building buildings, and just one CT scanner that we bought is 1.1 million pounds. They are really expensive bits of kit. We've tried to ensure value for money and try to ensure that we get the best return from our efficiency of our services by choosing the locations of them wisely and using our existing estate wherever possible as well. So I think we have tried to make that 30 million stretch as far as we possibly can.
Thanks, Mike. We've got lots more hands up, which is great. So I'm going to stick with those that have got their hands up, and we'll go to Joanne Goodison first.
Hi, can I ask, moving forward as a part of the future plans, is there any sort of consideration for the CDC sort of looking at sort of preventative diagnostics and looking at sort of opportunistic testing, for example, BP testing, as part of the sort of strategy going forward? You know, that would be the possibility of, say, BP monitors within community diagnostic centres, receptions, etc. Is that part of the sort of plan going forward, Mike?
You talking about blood pressure there, Joanne? Yeah.
Not just blood pressure. Gave that as an example, Sally.
Sorry, it's just also... you said BP, so I was just checking.
Oh, excuse me.
Pressure,
oh,
yeah.
Excuse me. Yeah, sorry about that. Yes, Sally, blood pressure,
yeah,
but also
no.
sort of atrial fibrillation. You know, opportunistic testing. Is there any consideration going forward as that?
We love an acronym, don't we, in the NHS? And I apologise if I've used a few myself, so I should have said that at the start. Absolutely, I think there are certain tests that are core to the community diagnostic centres, and there are certain tests that are nationally funded. So those have been the focus of our development so far for the right reason. But I think the more that we can enable testing to be done out in community locations, as comprehensive as possible and as close to the patient's home, but as early in their the possible diagnosis as possible, that's great. So one of the things we had focused on was mammography in Florence Nightingale, trying to bring some additional mammography equipment into Florence Nightingale Community Hospital. But yes, there are other tests that we can add into CDC locations over time. I think that's a really important point.
Thank you.
Thanks, Mike. Tony? Oh, can't hear you, Tony. Yeah,
that's it. That's it. It's flicking on and off as I keep touching it. Brilliant presentation, Mike. That sounds really optimistic and exciting. I run a community hub in San Diego, and part of that, part of our aim is to try and help people with preventative health and other things. So I'm also on the local PPG, and I do a daily briefing with people every day, largely using newsletters that have come through from Derby County Council about what's happening with health and all the things which are available. And many of the people that we have coming to our community are digitally excluded. So they don't get any of these newsletters. So we do this daily briefing to try and tell people, and you've given me lots of things that I can tell them about in my next briefing. But you did talk about people making their appointments and things online, which becomes a major issue for a lot of the people in San Diego, because we've got quite an elderly population, and part of what we're trying to do is to get them out of the home to come out to somewhere. And we've got some computers, but they're very reluctant to go on them. But our aim is to enable them to make all these appointments. So how do you get all the communication out to these people? Because we now haven't got any newsletters going through letterboxes or anything. So how do we inform people what's going on, and how do we enable them to make the appointments?
Thank you, and thanks for your work with the with that group. That sounds really great. I think part of the spreading the message is through fora like this, and you know, if there are other groups that you would like me to come and join and come for a cup of tea and a chat about community diagnostic centres, then feel free to drop me a message, and I'll do my best to turn up and tell you a little bit more about them all. I think digital literacy and not ensuring that we don't exclude big sections of our society, because I totally get the point that some older people don't like using the technology. Some older people, of course, do embrace the technology, and we should facilitate both groups of patients. So it's not a one-size-fits-all approach. We will still have a call centre. So one of the other developments at our community diagnostic centre in Florence Nightingale is a call centre function for all of our imaging booking. So they'll proactively contact patients, and they'll have the conversation about, oh, you live in Ilkeston or Long Eaton, you could go to an appointment in this location in Ilkeston and the wait's this long, or you could go to Florence Nightingale and the wait's this long. So they'll have a conversation with patients in a proactive way to ensure that they're still offered the choice of location, rather than being excluded because they don't happen to have smartphones.
Very good, thank you.
Great question, Tony. Thanks for that. Leslie Sermon, I'll come to you now as well.
Thanks very much. I just wanted to give you some additional information, actually, Mike, regarding High Peak and the Denton Community Diagnostic Hub. We appreciate that it's difficult for the ICB in Derbyshire to keep tabs on what's happening with High Peak. We are a bit out on a limb there. I'm disappointed that you don't know, though, I have to say. But we're already in conversation with Tameside and Glossop and JM regarding our position within that, and for Stockport and High Peak residents as well. So those conversations are alive and well. And we actually have just been invited, myself and Nicola have been invited onto the management committee for the Diagnostic Hub in Denton. Should say, perhaps, I'm Leslie Sermon. I'm an advocate for public voice and engagement involvement. I'm deputy chair of High Peak Place Alliance, and I'm lead governor at Tameside and Glossop Trust at the moment. And I also play a key role in Glossopdale Neighbourhood Group. So just to let you know, we are on this. We have got some really good relationships and good links. And I would say that if you want to keep up to date with what's happening, Place is probably, High Peak Place is probably the good place to join in.
Yeah, absolutely. And apologies, it's been a while since I had a conversation with anybody from that area about the development. So yeah, my understanding and knowledge of it is limited, because we've moved on from not being able to provide with the service in that particular area.
But that's where a difficulty is, Mike. You move on from it and then we're left stranded. And that's a difficulty. Now, we're not stranded because we have got the Denton Hub coming up. But we're the ones that have gone out to find out what it is that's happening for us. And you should have really been in contact with us to say, this is our position. We understand as Place that we've got a real role to support the ICB in trying to make sure that we're okay. And we're happy to do that. But we don't know what it is we've got to do until we know what it is that's needed.
Yeah, and I'm happy to come and join any Place meetings. I've been to a number of them across Derbyshire, but not High Peak. So yeah.
Well, thank you. That's my advice, and the reassurance that something is going on. Thank you.
Thanks.
Thanks, Leslie. Thank you. We've got 2 more hands up, so we've got a little bit of time left. So I'm going to come to Jocelyn Street now.
Oops, I think I'm now.
We can hear you.
You can hear me again.
Yeah.
Thank you. I thought that was a very good presentation, Mike, and I'm very heartened by what is going on. My question is to do with Whitworth. Now, for many years, I did the old Place examinations, patient-led ones at Whitworth, and there has always been a problem with the signage on the road getting to the hospital, which makes the turn difficult and not obvious. I'm concerned that they're now, and that is to do with the Highways Authority that wouldn't alter it. But you're saying that the facilities at the Whitworth Hub are not going to be what we would like, or not what you wanted because of the access. is this a permanent state of affairs, or are people working to try and improve that with the various authorities? And two, there's this difficulty in access. Does this mean that the mobile units are not going to be able to utilise that hub? And if this is the case, because the Whitworth is the hub that is serving, well, I'm pleased to hear about Denton taking over for the High Peak, but it is the predominant hub for quite a lot of a deprived area for services. So I was just wondering if it's great that it's up and running, but is that a done deal? Is that as good as it gets?
For the time being, yes, it is a done deal. So the Whitworth was the original site chosen back in 2021, and there was a business case developed, and the same mobiles. So we haven't got fewer mobiles. We've still got the same number of mobiles, but we essentially moved the business case from Whitworth, and we chose the Walton site in its stead because we weren't able to, from a health and safety point of view, get the vans onto site. And the reason for that was because of an access issue on a particularly wintry day for our one of our breast scanning vans, which are nowhere near the sort of size and weight of one of the MRI or CT vans. So it just became obvious that we wouldn't be able to put a pad at the Whitworth site, despite the sort of early investigation confirming that we would be able to. So we had to change our plan essentially and move in a slightly different direction, which I know it is less than ideal for that population, but we've tried to make the most of the site that we have got, and we've been able to put some decent investment alongside the League of Friends over in Whitworth to be able to invest in that site to be able to provide some of the facilities that, to the local population.
A quick addition to that too, with the cost of these expensive machines, in Sheffield they've had a lot of success in reaching out to the local voluntary sector and having organised specific fundraising campaigns to purchase those. Are you doing that in the Derbyshire and Derby City locality?
So we have huge charitable funds in the hospital, and we do have campaigns for specific pieces of kit. This type of thing generally tends to be stuff that is covered by system capital rather than charitable funds. The charitable funds tend to pay for things that bring additionality to patients and staff rather than sort of core clinical equipment. But we have used charitable funds in the past to buy individual pieces of kit when other sources of capital haven't been available. We haven't had to do it in this example though.
Thank you.
Thanks, Mike. Paul, I'm conscious you got your hand up, but I know we've got quite a few that have come in from the chat a little bit earlier, so I'm just going to come back to Mark for those, and then I'll come back to you, Paul. Okay.
Yeah, we have 3 questions. First of all, Julie Corn, very good question. Will there be any scope for direct access from community teams to prevent admissions?
Yeah, that would be great. That's exactly the type of thing that we'd like to develop. So if there are specific pathway ideas that people have got, then get in touch with us and we'll come and have a chat.
Excellent. The next question from Janine Patton. For Derby City, is there a planned pathway from UTC to the DCC for tests? I'm not sure what the DCC is in this instance, though.
Janine, do you want to come in?
Sorry, that was my spelling there. It's I'm talking about the Diagnostic Centre.
Oh, great.
Yes, absolutely. So we should be able to provide same day open access for patients, and it's not just at Derby City. Again, at Whitworth, where there's a minor injuries unit, there are diagnostic tests that they're working on providing alongside the minor injuries to keep patients from having to come to busy acute sites, keep patients as local to home as they can be.
Excellent. And final question from the chat that we have, Alison Ratcliffe. is there any scope to expand the testing available? The community team at the ICB are doing some work to look at improving the accessibility for Doppler testing, primarily for lymphedema, and wonder if it could be something that the CDC would be able to offer.
Yes, I think there are plans for Doppler testing. I'd have to check to be 100% sure, but I think there are.
And the only other thing I'd say, Mike, apart from the questions we've just done, there's at least 2 or 3 things in the chat that you'll need to make sure that you look at later, people trying to reach out for you for future work.
Thanks, Mark. Thank you. Right, I'm going to come back to Paul now. He's been waiting patiently.
Thank you very much. That was really interesting, Mike. Thank you. I should say I work for NHS England, but I'm here on the as part of Ken's patient participation group, so it's not a primed question. So when the community diagnostics were originally thought of, I think a lot of the ideas were you had them in football stadiums and Tesco's and all those sorts of things. I think Brighton Hove Albion actually do have a testing centre in their ground. Not that I'm suggesting you do that with Chesterfield or Derby, but I just wondered if there was any thought about how that might be deployed, because I think that's a really good way of getting people in to do tests. You know, you can go and have your prostate exam while your wife does the shopping in Tesco's or whatever, couldn't you?
Yes, absolutely. So we considered various different locations, and Derby County, Burton Albion were amongst those. There are advantages and disadvantages to having testing done in on non-hospital sites, and I think we're really fortunate in Derbyshire to have the network of community hospital sites that we do have, and in other areas where they don't have that facility, I know in Nottingham and in Nottinghamshire and in other localities, they haven't had that option to be able to build in community hospital sites, so they have had to look at other alternative models. One of the advantages of having on a community hospital site is the synergy between the diagnostic service and the clinical services that already exist in that footprint. And an example of that is things like CT scanners at our Florence Nightingale site, and being able to safely offer contrast to those patients without the risk of anaphylaxis. So if we'd have put that facility into Burton Albion or Derby County, it wouldn't have had the same clinical benefit from a pathway point of view and from a patient point of view. So that's one of the main reasons we decided. The second one is that sort of keeping the community hospital sites vibrant and thriving. Some of the estate in some of our community hospital sites that we're developing was pretty poor, frankly, before we've had this investment. And this helps to safeguard the future of those community hospital sites, rather than building something new and bespoke at a retail park or a football stadium, for example.
Okay, thank you.
Thanks, Mike. Mark, are there any more questions in the chat, or have we covered most of those off now?
No, I believe we're oh, sorry, one's just come in from Julie Court. How do community teams refer patients into the CDCs? So at the minute, the pathways are as they currently are into the acute hospitals. So the normal pathway exists for any referral into secondary care. I guess the bigger question is, how do we use this additional capacity for the community to benefit GPs, community teams, primary, secondary care, tertiary, all of the various different parts of our system, ultimately for the benefit of patients, so that we can, open access out to patients. Otherwise, all we're doing is increasing the amount of testing secondary care does.
We don't want to do that. We do want to get into the conversation about how we redesign pathways for greatest clinical benefit right across the system. We're not there yet. So to answer Julie's question specifically, currently people are referred in the same way that they always have been referred, I guess, until we do the work that changes some of that. And, you know, I'd encourage anybody that wants to be involved in that to get in touch.
And we have another one in the chat as well from Tony Ford. Being on the Nottingham-Derbyshire border, I get referred to Nottingham hospitals whilst living in Derbyshire. How does that link work? So again, we're talking to the Nottinghamshire ICB about ensuring that that facility is as accessible for Nottinghamshire patients as it is for Derbyshire patients. And you know what this shouldn't do is determine that if you go to the Ilkeston CDC, you then have to go all the way over to Derby if you happen to work and do all of your normal activity over on the Nottinghamshire side. So we're very keen that the facilities are able to talk to the system in Derbyshire and the system in Nottinghamshire, so the GP can choose where to refer you and to access a local diagnostic test that helps to facilitate that pathway. So we're keen to facilitate patients being able to go to both in the Nottinghamshire direction and the Derbyshire direction.
Great, thanks, Mike. And I think we'll finish there because it's there's no more hands up, and I think we've answered all the questions. As Mark said, have a look through the chat because there's loads of link ups there for you, Mike, to develop the conversation, which is great. And thanks very much to you, Mike, for a really informative discussion, conversation, presentation today. Our next session is on Wednesday, the 20th of March, between 1 and 2 p.m, and that's on social prescribing. So hopefully everybody could join us then, and please share the messages and share the information about future Derbyshire dialogues as well. That session will be facilitated by Lee Meller from our team, not myself. So just to say thank you to everybody. Thanks to our British Sign Language interpreters for keeping up with the conversation today, which is great. Thanks for all the questions. A great conversation today. So and hopefully see you all next month.
Thank you, Mike.
Thanks for inviting everyone. Cheers.
Thank you, everyone. Thanks,
Thank you.
Bye bye.
Cheers, bye. Thanks.
Thank you.